collaborative webinar. As people are coming in, just encourage you to go down to the globe at the bottom and click on the interpretation button, and you can select English or French. That enables us to have dual translation. So if somebody asks a question in French, then we can all hear the answer in English too.
Good afternoon.
Hello, welcome.
Thank you. I'm Zandi from Eswatini.
Great, good to see you. We had a good number of people booked. I think on our bookings we had people from 27 different countries. So we really are a global meeting today.
Though my time will be limited because at 4:30 I'll start with another class. But I appreciate the invitation and the participation.
Yes, thank you for joining us.
Thank you.
As we start, let me share some housekeeping as we get going. I encourage you to keep your microphone muted unless you're asking a question. We will actually have, because there'll be so many of us on the call, we'll use the chat function for questions predominantly, if we can. But do feel free to use that chat function to comment and to ask questions as we go, and then we'll have slots during the call to have discussions with our speakers. The session is being recorded. We'll upload it to YouTube and send out that link to email addresses who booked on in the days following this call. We are a collaboration today between Arukah Network, Tearfund, and Christian Connections for International Health. So we're really grateful that so many people have been able to join us. It shows the importance of the topic, doesn't it, that so many people have booked on to the call today to join us. And we do hope this call will be the start of a conversation for us, this really important topic. The more people we've spoken about the topic, the more interest there's been in the lead up to our call. And so we're just really excited to start this conversation and see where it leads us. We've still got lots of people joining us, so I will just keep chatting. If you need translation in French particularly, then you can head down to the interpretation globe and click on that. And again, let me encourage everybody to do that. You can click on there and click English if you need English, and then that will mean that if somebody asks a question in French, then we can hear it translated into English. Really grateful to our interpreter in French. Later on in our call, towards the end, we'll be breaking off into breakout rooms. So there'll be a choice of rooms to go into, just to discuss in slightly smaller groups how some of these issues work out in our contexts and what we might be able to do together going forward. Thank you to those who are introducing themselves in the chat box. We've got lots of people coming in. Let me start us off by setting the scene. We know, don't we, that digital connectivity, the internet, digital technologies are growing all around the world. That goes without saying. And they're powerful catalysts, both for economic growth and for development and particularly in the context that we're thinking now, health development. And that's especially true for those living in under-resourced communities, marginalized communities. Being connected digitally can be so powerful, but it also comes with real challenges. So we want to think today about the accessibility, the affordability, and the different challenges that getting connected digitally brings, and the particular impact that is having on community health around the world. We're going to explore the benefits of being connected, and what people might be missing out on if they're not. And as I said, we want this to be a conversation starter for all of us. And to kick us off, I'd like to share a tool from Tearfund. These concentric circles give us a tool to consider who benefits from being connected, if anybody's been disadvantaged from being connected, our interests that drive the development, digital connectivity, and maybe who is being left behind. This tool helps us just to visualize the questions related to that, doesn't it? And if we consider these 5 A's from the outside in, it helps us to measure and work out the steps required towards digital connectivity. And it's true, isn't it, that being connected isn't a binary issue. Digital access is non-binary. There are different ways of being connected, aren't there? So being connected digitally is one way, and we'll talk about the benefits and challenges of that. But we must be aware that people in communities are connected. They've been connected for thousands of years. We've been made, haven't we, to be in community with each other, to be connected to each other. And so these 5 A's I find really helpful to help us just consider the challenges, the benefits towards connectivity, and trying to do it in a thoughtful way. As we start off, our first speaker for me to introduce, in the beautiful irony, I think, of this whole topic, is a pastor called Pastor Burton from DRC. He's one of our cluster leaders in Arukah Network. He leads 3 of our clusters. And the irony of this is that we wanted to have him connected, but he couldn't get enough connection, a stable enough connection, to join us on Zoom. We then asked him to send us a video, and his connection wouldn't allow him to send us a video. So I've got some audio from Pastor Burton from Lubumbashi in DRC, which I'm going to attempt to share this audio with some subtitles for you to introduce you to the challenges and the benefits of connectivity there in DRC. So let me do that now.
Connection much more faster, much more. The benefits to be digitally connected as a leader is making the connection much more faster, much more quicker than with the formal way of being connected. Like when somebody is connected to the other people, the other persons outside or inside, they need to communicate to connect through for the mail, for the post office, or through I don't know, through any other way than the digital way. And the challenge, yes, there is a number of challenges for the people not connected digitally, because they are missing opportunities to be connected much more faster, much more quicker. And it takes time, it takes a delay for them to get connected. We've been experiencing this kind delay when when people have been waiting for answers from the people, mostly officers, when they wrote a letter and they are expecting an answer to come through a letter through the post office. And we know the people have been waiting for a reply, for answers through the post office, and it has taken as long as 2 or 3 years to get replies or to get answers. And so they are missing a lot of opportunity to get connected faster, because when you get connected digitally, you get the answer, the reply, and in a twinkling of the eye, so as fast as you can expect. So myself and other leaders in my community, the way we have been approaching this challenge is, the first challenge is many people in the community, or most of them, do not have or are facing the challenge of not having smartphones or tablets for them to be connected, because I know it is very much difficult or quite impossible to be connected digitally without without a smartphone or a tablet or laptop. This is the biggest challenge in the community, and including the leaders I work with, including the leaders as well. So getting a smartphone or a tablet or laptops, this is the challenge number one. And the way to cope, the way to solve out and sort out this challenge is pleading, is asking, is praying for donors, both locally, nationally, or internationally, to help and to assist. It would be much more easier, much more, this could be done much more easily if the local people could get the resources, or enough resources. I know they are there. They have been working on that to raise funds locally, so that they could get smartphones or I don't know, tablets or laptops. But so this still remains the challenge. And our prayer and our question, our prayer is for other donors, well-wishers, or sponsors that may be available to assist in this need and this challenge to be solved and to be sorted out, so that the local people, not all the local people, maybe some persons in the community, or maybe within the team of Arukah Network, within the team, so that they can, once they have access to smartphones or tablets or laptops, they could be digitally connected. And now, once they are digitally connected, they could have access to communicate, not only locally or nationally, but internationally. They can participate in online conferences and online training, online meetings with the people outside the country. So now this is our prayer, and this is our prayer, and this is our question, that we ask for help, so that we can sort out this challenge about being digitally connected. Thank you so much for the questions, and I hope that this piece of information may be helpful.
So that sets our scene from Lubumbashi in the Congo. I know from chatting with Pastor Burton that he would love for more of his leaders to be connected. But as you heard from him, their challenge is just physically getting their hands on devices and then being able to use those devices. I love that phrase, the difference that between 2 to 3 years at the post office to the twinkling of an eye for answers. That's such a difference, isn't it? Such a nice way to put it. The benefit of being connected is getting information in the twinkling of an eye, getting your answers in the twinkling of an eye. What a difference. Let me introduce now 2 speakers from the Christian Medical Association of India. We have Dr. Abhijit Sangma and Christopher Peter. Christopher is the communications lead for the Christian Medical Association of India, and Dr. Abhijit leads the doctors. He's the celebrity doctor of CMAI. Chris said that was his introduction to me. So I'm really grateful for them to joining us. Let me hand over to you guys, and I'll share your presentation as well. Thank you.
Right. Thank you, Tom, for playing that audio message from Pastor. It's heartwarming to hear. And one word that comes to my mind clearly is that we are privileged. Those who are connected, it's a privilege. There are many in the past who have waited for years for development, and for some, it's still the case. Well, I enjoy this privilege to connect because I am from India. It's a good evening from here. We represent Christian Medical Association of India. Me and my colleague, Dr. Abhijit, as Tom has introduced, we are here. Thank you for joining us. So when this opportunity was shared, it came through my friend Jude Collins, who's the editor with Footsteps at Tearfund. And at that point in time, she said, "Chris, would you be able to join in a call?" I said, "All right." I didn't know that I'd be getting into this. So the theme is important, it's intense. And so is the case when I started speaking to our community leaders. So before I begin, I'll just like to quickly brief you about the organization that I represent. It is CMAI. And we've been operating in our country since 1905. And the 2 visuals, I hope you can see the screen. The 2 visuals that we're trying to portray is, one on the top left is where there is a bullock cart. So, years ago in our country, the missionaries came setting up medical missions. And those were the days when healthcare or medical missions or support or doctors were reaching out to the community at their doorstep. And that's the real essence of community, and it remains even today so. So we've been working on medical missions and healthcare. And on the right hand side, is the slides working, Tom? If you could just move to the next slide. Thank you. Yeah, so on the top left is a bullock cart where medical teams reached out to the village, at the remote location, interior locations as what we refer to. And there's a journey as depicted through an arrow. There's a transition. That's our legacy. Today, we do go to the doorstep of the communities, but by God's grace and His faithfulness and the provisions that we have, we reach out in a vehicle and with our medical team. So at CMAI, that's the journey that we have, the legacy we have. And we have 5 sections primarily at CMAI. Doctors, one of the section that Dr. Abhijit is heading. Then there's nurses and chaplains, the priests, the pastors, and allied health, lab technicians, etc., and the administrations who run the businesses and admin of the hospital. Move to the next slide, please, Tom. Our strength is our members, both individuals, more than 10,000. Over the years, we've had members from different sections, from different professions, and member institutions that we refer to, what you know of them as mission hospitals. We have about more than 270 mission hospitals. So these geopins that you are looking at, which is, by God's grace, filling up our entire nation nearly, are the mission hospitals that I get to speak with, interact with, and hear their stories and create documents for them from communication team. So when this theme came up, it is about community. So if it is about community, it has got to do everything with the people that we're talking about. So might as well go behind the curtain in my presentation at a later stage and give the center stage to the people from the community. So the structure that we followed is that right after these few slides, there is a video that is edited, created. And in that, what we did is that we connected with a few hospitals who are engaged in community work and basically responding to a few questions that we shared with them. And those questions are about how digital support or technology in community work has helped, given opportunities. There are some challenges, and what has been gained. What are the win-win situation for the community workers and leaders when it comes to digital technology. I'm sorry, because the session is on digital, so you will be hearing this word digital technology, tech, and gadgets, and quite a bit much. But what I'm trying to really bring to you is the voices of the people, because their experiences has been a journey, even for me, the last 3, 4, 5 days that I spoke with them, connected with them. I've realized, and adding to what Pastor just spoke, that it's a privilege, and just overlaying that, it's a huge honor for us to even connect and to be able to hear them. So that is at a later stage. Next slide, please, Tom. So, yeah, you can catch up to know more about our organization on the website cma.org. So the first question in the next slide is, what is gained from digital connection? We all know what we gain from technology, that it's a huge support, that it enables you, it propels you, it builds a capacity in you. So likewise, even for a community workers and leaders, it has improved the communication. So there were opportunities which would go unaddressed, and those opportunities digital has brought in, the system has brought in. And at the remote locations, at the interiors, the villages, a mobile phone, a simple, smart mobile phone is the biggest gadget, is the most techie gadget possible, right? They might not have laptops because there is a problem, the challenge of electricity, basic issue over there. So it has not only improved the communication, many times that I heard from the community leaders, that it has even created communication channels in context of the leprosy, in context of HIV patients, those who were living quietly preferred not to interact. They, from their close corners, quietly from their rooms, have opened up their lives, have opened up their hearts to speaking with the counselors. So it has even created communication channels and definitely improved communication. Patient care is the #1 goal and objective of our people in the community. It has built their confidence, enhanced that from that perspective. The teams who in now day and age reach to the community carrying mobiles or gadgets, they feel that I could sense that they were confident, they were sounding confident, and they were very happy, because otherwise these gadgets and everything is only available to people in the cities and in the towns. So they were happy, it strengthened them, builds the confidence. The travel costs definitely, because it's saved, and the reason is because there is a cost that comes to the community team, because when they travel from the hospital to the village, Now, I'm not saying that they are cutting corners or they don't or looking for excuses, not at all. But for a simple, just information over a call to say, okay, you can take this medicine, is fine. That's what they said. And so it helps us save costs, and it's a matter of convenience as well. Efficiency, definitely it increases because the data that is captured is no more in books and registers and kept layers over the layers over each other, but the data is available and data can be analyzed. So there is good monitoring, and they can always, and the community people are going back to the data and saying, okay, last camp we had 15 people. These are the 15 people. So why don't you go and meet those 10 and I'll go and meet the other families. So it's making them efficient. And their ability to respond, you know what mobile phones can do, connections can do, and the access to information that is there. Yes, we know there is a lot of strength, there's a lot of ability in this digital connection, but it also has more or less same number of challenges. In the next slide, you'll see we just tried to put a few questions. That's the second question that was shared by Tom and his team, that what is lost, what is missed, what are the challenges? More or less, they're right now going hand in hand in context of my country, that if there is no electricity, your gadget is useless. If there is electricity and it is charged, but if there is no network, it is again of no use. Yeah, you can take photographs and record voices, but then in your community work, it doesn't serve any purpose. So that's a huge challenge that the community people, workers, they shared with me. That's why the second point, availability of mobile networks and the reach of the technology. Once they have it, and there are possibilities of training, but it takes a lot of time. So you have to build that capacity in them. And so training is possible, even for simple usage, using the mobile phone, the switching on and switching off, and taking a video, landscape or portrait. If you're a research person, then noting that data, Google Sheets, these are all new for us. These are all day-to-day life. But for others, it's a huge privilege because the background where they come from. So we have to understand that we can provide the gadgets, but we have to allow them to learn, and yeah, that is important. So one of the most powerful one that came was lack of trust. Over years, it takes for people to build a relationship or a rapport with the community. They've gone years and years, quietly visiting, having a cup of chai, tea with them, just having that and coming back to the hospital and going again after 10 days over the years. Now when a community person goes and takes a photograph, and if it is misused, the entire relationship with the community is gone, sadly speaking. And yes, when you have all this data, when you have these photographs, when you have these videos, there's a constant threat of data getting breached. But how do you protect the data? In order to protect data, you need systems. We know that. And everything that you involve, where system is involved, there is a cost involved there. So these are the challenges. But at the community level, what the need is basically going slow, basically walking slowly, gradually approaching, and then teaching them the skills. The information that is available, that is the information that is available also has to protect it. But more and above, the choice between gadgets or people. Do I go to the community to go and meet them, interact with them, or I can just make a call and finish it? The good news is that the people from community they never choose, they never go, they never look for an excuse. They always want to go and meet the community. Even during COVID time, they did. And you'll hear them as they speak briefly. The next slide talks about the opportunities. It builds the infrastructure of the hospital. They never had, they did not have internet, so they got it. Now, when they have an internet at the mission hospital, they're connecting through Zoom, and they're also, they're able to download information. They're able to access information which is globally available. So it's building the capacity of the hospital in our case. There is a need of digital literacy, so they invest in that, and those are the opportunities. So herein lies an opportunity for organizations to come forward and say, here we are. If you need any help to train the community team with basic skills of mobile technology, data protection, analysis, we are right here. I think as organization, we should converge to offer simple help as community leaders and workers intend to do the good thing and use the digital systems. Now this is about the telemedicine. So there are guidelines, and at present what community people they are doing is talking about basic healthcare and talking about the medicines if it is available, and if it is not, then they are requested to come to the hospital. So the use of telephone or mobile with reference to healthcare is limited in our country, and we are moving a little more safely. There are guidelines attached to that. If people from community, if people here, if you have any questions or you want to ask something more about telemedicine, please ask. Dr. Abhijit is here. He'll be, here to help. Abhijit, do you want to step in and say something on telemedicine?
Just to give you a context, I mean, if you look at India, India is a vast country with a lot of population still living in rural areas, and also it's like 70% of people they live in rural areas and 30% in urban areas. And also the context is 80% of doctors are in urban areas and only 20% are in rural areas. So if you look at this context, and also the evolving of telecommunication in India and the penetration that we had over the last decade has been tremendous, and government has been able to build a lot of infrastructure to connect as far as possible in the remote areas, and also electricity, and not just telecommunication, electricity, and also build infrastructures in those lines. So that gave a good, a good platform from India to connect digitally for healthcare service. And it was COVID that pushed the whole thing, accelerated the whole adoption of telemedicine in India. So government also has just during that time, the beginning of the lockdown, came up with the telemedicine guidelines. So which, it was happening informally, it was happening, people would call up doctors and seek consultations, but government worked on guidelines to formalize it and to ensure quality, ensure safety, and to ensure standardization of the process. So that's the whole telemedicine context in India as of now. So with currently what is happening is not just the government, but also the private health institutions have got into providing telemedicine solutions. And if we look at mission hospitals and the network that CMI has, one of the things what we have been able to do is reach out to the communities where, because we had our, out of 273, we have around 60 to 65% of our hospitals have community health projects. And digital connection has been able to establish, with digital communication, they've been able to establish the connection from the community to the hospital. And that has been quite fast, and They also have been able to provide digital connectivity through mobile phones to the community health volunteer who's based in the community, in the rural areas, in the remote areas, for the hospital to at least get in touch with, to know what is going on. And I think Chris will be able to share several stories that has come up from there. So I'll hand it over to Chris now.
Yeah. Thanks,
Chris,
Abhijit, on that. Sorry,
I was going to say, shall I share your video?
in a minute. I'll
Yeah.
give you the cue.
So just another thing is, one of the things that is still adoption is a little slower. I mean, it is, in fact, it has been quite good, but it still takes time for people to, taking time for people to build that trust on telemedicine. But one thing that has happened within at least our network is some of our hospitals which are in remote areas have been able to connect with specialists regarding any cases, complicated cases they have come across. And they were able to connect with bigger hospitals, with other specialists to consult and then provide treatment. So these are some of the things that has happened because of telemedicine and the digital communication. Yeah, Chris, sorry.
No problem, Abhijit. Thank you for bringing that aspect from telemedicine. So there is a lot of work that locally hospital and the community is doing, working along with the government. And you'll hear one of the stories talking about how they reached to the local officer in the government and requesting them to create an access to basic electricity and network. Yeah, so on data analytics, there are organizations who, because there's an investment, they have data, they're using it. But in our case that you hear is only an organization which is already into research. So it is imperative that they do. There is a lot of opportunity for mobile health applications at present. And there are, because it will be from case to case, from community to community, and basically where they're located. Hospital management systems do exist, where all data is captured and used and analyzed. So all of that is there. Overall, when looking at all these three questions, and at this moment, I'll request Tom to play that video. And these are our people from our community. They are the leaders who are working at our mission hospitals and from CMA network. And after this, we conclude our talk, our presentation, once this video is played. And after that, we'll take the lead with Tom as if there are any questions to follow. Please go ahead and play the video, Tom.
This is very helpful for us because previously we had to go, staff will go there, he will write the information, details about the patient. But now we are getting direct information because of this technology, as we have provided, supported to the community leader. Sometimes it should be legal unless he gives a proper information and right information. And there won't be a network or a coverage area where he can pass on the information on the right time. Sometimes it also happens the misuse of photographs, misuse of stories. But as we trust the person who is the leader, Mr. Anil, he gives us a proper information and very reliable person. One of our village, Katawadi, where we do not have proper electricity and network. So as we work with the community, even they find like they cannot call ambulance 108 to help them. So as a community, we went to the BDO, Block Development Officer, and given a letter for request that there should be a tower where the community gets network.
So mobile technology has given lot of opportunities in our community work. I can explain this with the example of a patient whose name is Rekha, and she was from Bihar, and she was diagnosed to be suffering from leprosy like in Bihar, and she was on anti-leprosy treatment. But while treatment, she got some ulcers and all, and therefore she was referred to one of the government hospitals. The government hospital also tried to treat her, but she was not Her ulcer was not cured. Ultimately, she was referred to the Leprosy Mission Hospital, Shahadra. When, although she was from Bihar, she is still in direct contact with us through mobile connection, and she is in direct contact with us. So by the use of mobile technology, we can say that she is very comfortable, and although she is living far away from our hospital, she is still in contact with us, and we are able to guide her. In some way, we are able to help her. Without this technology, might not be able to help her in that way. For leprosy, we are not able to develop any app or any application through which we can have a direct access, or that so that patient have a direct access to us, and they can send us report on a weekly or monthly basis, like whether they are taking the medicine or not, whether they are having ulcer, what is the size of ulcer, whether they are doing self-care daily or not. So we need to develop all these technologies for person affected by leprosy, so that they can be cured, but they can get the better treatment, and they can lead a disability free life. Reach in the community has been increased, and most of the time I can say, with this in current era of technology, nobody is left behind.
प्रेजेंटली हम लोग जितना ऑडियो विजुअल एड्स हैं कोरोना के बाद हम लोग इस्तेमाल नहीं कर रहे हैं। बस फ़ोन पे जितना भी गाइडलाइंस हम कर सकते थे पेशेंट्स को, वो सारे कर रहे हैं, और जो मेडिसिन्स, जो गाइडेंस चाहिए पेशेंट्स को, वो लोग हम फ़ोन के ज़रिए उनको प्रिस्क्राइब करते हैं। लेकिन प्रेजेंटली वी आर नॉट इन्वॉल्व इन एनी काइंड ऑफ व्हाट्सएप ग्रुप विद द पेशेंट्स। तो व्हाट्सएप के ज़रिए, लेकिन इंटरनेट के ज़रिए हम लोग आगे उनको गाइड किया जा सकता है। लेकिन अभी फ़िलहाल हम लोग को कोई ऐसे गाइडलाइंस नहीं मिला है, ना ही कुछ जानकारी है। अगर स्टाफ को या फिर डॉक्टर्स को इस बारे में कोई ट्रेनिंग दिया जाए तो प्रोबेबली हम लोग फ्यूचर में अच्छा प्रोग्रेस कर सकते हैं। पेशेंट्स को और गांव में जो रहने वाले जितने भी हमारे कम्युनिटी एरियाज़ हैं, सैटेलाइट सेंटर्स हैं, तो उन लोगों को हम लोग कवर कर सकते हैं और उनको गाइड कर सकते हैं। तो अभी फ़िलहाल जितने भी एरिया हम लोगों ने कवर करा है हमारे 10 किलोमीटर के दायरे में, more than 80% people they are having Android mobiles. So ये टेली मेडिसिन के ज़रिए हम लोग उनको अप्रोच करें तो शायद फ्यूचर में हम लोगों को कुछ बेनिफिट मिले। थैंक यू।
So once in a week, our health team goes there. We set up in our tele center, and we set up a teleconsultation. We call all the pregnant women. So they come to us in that, and we have a staff who does the monitoring of the patient, and then we have a consultation with our obstetrician. So right now she's in UK, but she's able to do a teleconsultation with us here. So we fill in a Google sheet again. We register the patient with our HMS, our hospital HMS. We register the patient in that, and then we have a teleconsultation with our obstetrician, because that was a major challenge, how to teach them to use a smartphone, then how to train them how to use a Google sheet, how to fill in a Google sheet. Those were the initial challenges that we faced. Then the second challenge that we had was some of the health volunteers are young, so they are very smart, so they know how to use and misuse the phone. So what we had done was we had kept parental control. One child who was actually a child laborer, he was working in Punjab, and he developed a foot ulcer in Punjab. And during one of our health camps, we were taken to this child, and he was basically outside the house. He was kept outside the house, and he had a big foot ulcer, and it was smelling bad, and nothing could be done there. And he was because the parents had they were migrant laborers, and during COVID time they didn't have any money. They spent everything they had, so they had resorted to faith healers and quacks, and his whole foot was covered with some mud and cow dung, and he was literally outside from his house. So it took some around 1.5 to 2 months to treat him. Till that time the mother was also here, but it took a lot of toil on the family, because they were not able to, the whole process of their family was disturbed. They were not able to go for job, no money. So once his foot got better, we taught him how to dress it, how to do things, and we sent him to the village. There this telecenter helped us, because the village that he was in, we had a telecenter. So this child would come to the telecenter.
No, people want us only, not in digital. Actually, we have 600 and change leprosy patient is we have record. So some people will come 2 months regularly, then third month little bit they're better, they won't come. So immediately we have record. Immediately I should call the patient. So according to that, we are using mobile. It's very useful mobile for us because of leprosy patient. That's the reason now so many people from RF relief from the treatment. Otherwise, off time they'll take treatment, off they won't take because of the mobile. So now patients, so many patients completed MEMET.
Begin.
As a part of digitalizing our data that we can, we get in the field, we would like to store that data in a password protected iPads. The problem with phones is they are quite small, and to administer a questionnaire on a phone, it is little difficult for the enumerators or the nurses who are actually talking to the participants or the patients. So what we do is we take an iPad to the field which is password protected, and each enumerator or the nurse has the user ID and passwords which she will use to log in and get the information, and it also has a fingerprint so that nobody else opens that ATM. Well, for research purposes, we always want to maintain privacy and confidentiality of the information of the participant or the patient, and we don't want to share it to everyone. It has to be maintained in confidentiality so that the participant is assured that what we are doing with their data is safe. Yeah, so most importantly, actually, to start people using the iPads in the field, before that we'll at least have 3 months of training for the nurses. 3 months solid, because we have got multiple number of questionnaires, questionnaire for clinical history, anthropometry, biochemical station, and we would like to know like the different aspects, mental health, clinical diagnosis, COVID situation, any infections that they would have had, any TB infections that they would have. Like we have different questionnaires for different types of ailments. So we train them very well, and we do mock surveys here itself at AMC before they are actually going into the field. And we observe them, like how they are doing it, and if they are very confident only, we send them out to the field. So after that, and the thing is, like in the field is, like we charge all the iPads on the previous day just to be on safe side, because otherwise that becomes a challenge in the field. If iPads are not charged, then, and if there was no power on the previous day, for example, it was raining heavily here and there was no power, for example, we couldn't charge the iPads, then that becomes a problem. And another challenge is that, at that time we use power banks, because we have to charge at least 30 iPads for 30 enumerators to go out. Okay, and the other challenge is sometimes internet also is an issue when we go to the remote villages. So talking about digital and community health, it's very important, otherwise it gets very difficult. We do need digital, I totally agree. Even for community villages to identify also, we want a Google map. We also want, let's say, a GPS to know where exactly this village is. Like we can't dream that the village is there, we can go just like that. But if we have a GPS map, we immediately move there. It's easy, right? But we can reach through that point, but to reach the heart of the person, you need to talk, you need to go there.
Great. Well, thank you both for your presentation. Thank you for all the work put into getting all that those contributions from so many people out in the field. Really, really great to hear that and hear from so many. So thank you. We've got time. We're running short on time, but we've got Elvis. Elvis, are you with us? Elvis is spent many years working in the field in rural Zambia. Elvis, are you still online? He messaged me yesterday saying they're expecting a cyclone, and so his connection might be limited.
I'm here.
Elvis, good to hear from you, brother. Just briefly share your thoughts on this topic, just a couple of minutes, on your experience of the benefits and the challenges around digital connectivity.
Okay, thanks. Good afternoon, everyone. After listening to the India presentation, I decided it's not worth going to present mine because they've covered almost everything I was going to say. Anyway, I'm a village boy. I actually grew up in a rural area and they've worked a lot, many years with the Salvation Army and other church organizations in the rural areas. One thing is nothing will actually would replace a face-to-face visit when you are in the community. It feels very nice. I'll briefly give you a picture of Zambia. Zambia is land-linked, and a lot of people actually know us. I hope you do. We are 18 million people, growing at 2% yearly, and most of the population is in the rural area. Our disease patterns are actually preventable disease, and we have 1 to 12,000, about 12,000 people to a doctor. In terms of coverage, with mobile phones, we have 93%. The only unfortunate part is at the moment is actually 2G. But we have a lot of radio stations spread around all the districts. And we have electricity in most of the places. We have solar. There's a lot of sunshine here. And the Zambian government has been doing some what I would call smart care in terms of patient records and data collection. Now, as a leader talking about digital health, we started off with HIV, and then COVID came, climate change and migration. To me, these are actually signposts to say the way we present health has got to change. And the other thing that you find is wellness has become no longer vertical, it has become very holistic, moving away slowly from prescription to participation, which is a nice thing to see happen. As in terms of HIV, what I experienced is people enjoyed being attended to at home. Emotionally, it was very good for them and it helped their recovery. Digital health does reduce on cost in terms of travel. I have been running around on land cruisers and sometimes they break down. A lot happens. Of course, there's a reduction in cost. Adherence, it can help in the area of chronic diseases, monitoring adherence to treatment, especially when you involve family. Surveillance of and data management is another area of benefit. My last posting was district manager. I moved from church institution to a government one. And I'm just going to share a short story of my experience. I went into stores to check on the drug supply, and I found boxes and boxes of ARVs. I asked the guy who was looking after them to say, what's wrong with this? Because it does not resonate with the number of people we had. And he told me to actually keep quiet and not send them back because it would ruin all the data that is in the country. I hope I don't get into trouble over this story. He was simply saying we could not return these drugs. Somehow they should stay in the stores. I didn't like it. I was thinking of a way of solving this issue. Lucky enough, a few weeks later, I went into a community in another district with the Catholic sister. We had a meeting with young youth. During the meeting, I found out that in that area, they had a shortage of ARVs and they had resorted to sharing. The reason was transport to get to the district to collect. So they were sharing with the arrangement that the other one, when they collect theirs, they will share with the other. And there's another funny part to it. I found out they were actually reusing condoms. After using them, they would wash them and use them the next day. What I'm trying to point out here is, if digital health is approached properly, it would actually result in ownership, and it would help with data management, because the boxes that we had were going to be thrown out or get burnt. I know that in certain districts, this is what has happened. But anyway, in this case, I actually discussed with the youth and a few civil society organizations on how we are going to use these ARVs without disrupting the system. This happened. But then there are issues of adherence. There are issues of human rights. And when these are actually, when you have the right technology, you can actually snuff out these things that happen in the community. That's what I learned. In terms of governance, in Zambia, the government is willing, but everyone knows that government has a lot of issues in implementing something. In Zambia, players are already in terms of the Ministry of Education has actually increased online education using mobile phones. The other snag is the financial backup. There's very little money around. In terms of human resource, we don't have well-trained staff. There's need for training. Electricity, like I said earlier, is available. We have the sun all the time. Leadership, I think this is the critical question for me. I have always asked myself on how we can actually change leadership. Not only at the government offices, in the church, in the village. The one thing that I've found is real leaders are plenty, but we don't know how to fish them out. When you ask me who a leader is, my answer would be the ones that I know and the ones that I've met are people who have a self-regulating power of being in the moment. They have awareness, and they actually can grow a system once it's implemented. Maybe the best illustration or story I can allude to is Jesus and the lady with the issue of blood. That to me is the type of leadership we would need to go digital in countries like Zambia, because a lot is happening on Facebook, TikTok, what have you, and there's a lot of abuse. There's very little legislation. If I were to recommend something else, is why don't we do it to help government by approaching it in the missionary style? Pilot programs in certain areas, provide mobile phones and link up with radio stations and mobile phone providers. And then civil society is critical in terms of human rights. They should all be in. And that I should have mentioned that when you talk about governance. In most times we've left out civil society, and it has resulted in a mess. I have actually picked out just what India did not cover. Thank you so much.
Thank you, Elvis. Some really interesting points there. Particularly want to pick up on one of your points about affordability and access to internet. We've had a couple of questions on that. So maybe to all our contributors, that we had questions about whether we should be providing devices for people or helping them to buy their own device, and linked to that, the issue of internet connection in rural areas. I just wonder how you guys would respond to those kind of questions. Who wants to go first from our panel? Go on, Elvis. What in your experience in the communities you're linked with now? You mentioned governments providing devices, and would there be connection to the internet if those people had devices? And do you think it'd be more sustainable if they were able, if they were supported to get resources to buy the devices themselves? What are your thoughts?
My first port of call would be training. We need to train these people to understand not only how to use readers, but how to manage them. Because we've tried, and there was some level of abuse, or maybe developing conditions that should be followed.
Yeah, thank you. One of our intentions as Arukah Network is to be supporting each other in communities and helping train and rather than provide finances, we try to help support each other to be able to find sustainable ways. But sometimes people just need the help to get connected, don't they? Another question then, particularly for the CMA guys, do you think the benefits for digital connectivity are greater to the organization or to the end users living in the communities? Is it a benefit to both, or is it more to those who are trying to deliver the work?
I think it has benefited both the sides, actually, to say community, because they have now access, and also for the hospitals. I would speak about hospitals and community health project, because we also have now access to the community, better access, better penetration, and better access to data. Because now, if we want to do a small study, it becomes much easier because we can quickly administer a questionnaire through the phone and get the opinion, and know what is going on. And this has also helped us to know where the cases were high, in which villages, so the hospitals were able to have the intervention based on where the COVID was, higher cases were seen, and where they could go and do their provide care. So it goes both ways.
Yeah.
Thank you.
Yeah, thank you. I guess as care standards improve, health improves, doesn't it, in those communities? So that's direct benefit to the end users. Yeah.
Yes, definitely. Yes.
Yeah. Thank you to Jean for her comment based on that question. End users definitely benefited from better informed and trained health workers in MATLAB Bangladesh. Yeah, and I guess in different places, with the issues here are different, aren't we? So in some of the communities that I know that Pastor Burton is working with, he's thinking about how his community leaders and community members are connected, and their own ability to access information. Whereas for CMAI, it's about training health workers and giving them access to be able to use them in the field. Is that?
Right, true. And even from away from the periphery of the mission hospital, even within the community, the leaders and the workers, even their connection is of primary importance, because for information, for medicine, for guidance, for healthcare, they connect back to the hospital.
Yes. Yeah.
I wonder if I could just make one comment, if you can all hear me. I've worked quite a lot in India, but also a little bit in Africa, and I'm very interested in the whole community, the whole sort of the real community base, the people in the most remote areas, and also in the poorest areas in cities. And of course, we need the leaders desperately to have smartphones and so forth. But it strikes me, if we within our communities can work with the government or with other appropriate faith-based or other community organizations to make sure that we've got well-trained community health workers who have smartphones and who can use them well. This is an absolute central plank of the way the whole enormous community health worker movement can move forwards in different countries. There are now many millions of them. If each community has got a community health worker with a smartphone, this brings information backwards and forwards. And it also is a nexus within the community for people to gather around and communicate and learn. So somehow we need to work hard with the leaders, but also with the CHWs. Thank you.
Hello, Ted. Even in the work with community, there were a lot many stories, but we were paucity of time. Not all of those stories are put together. But when Ted is talking, just comes to my mind immediately is that it's not only the basic usage and provision of mobile phone, but a little more developed a center at the at the community level, like which saved that little child from child labor. So it's a gradual progress. But like you're talking the army, it's just 5-6 people that we heard, and if I believe we would do listen to stories of people how they're using digital across India, I'm sure the number would be huge. A video would be like a feature film, perhaps, to play with. But a joy for us to watch who work along with the community. Brilliant point, Ted. Thank you so much.
Just to add, we do have hybrid centers as well, where the community health workers are based in a small health center in the community, which is connected with either just basic monitoring, and the patients can come to the centers, and then they are connected to the telemedicine center of the hospital there with the specialist. And the nurse who's based there in the community or the community health worker, they can take the basic parameters and then share, and also some and then the telemedicine, the whole telehealth process is done. And government also has been there's by policy, we have in India, the cost of internet is really low compared to many other countries. So those have really helped in adopting or penetration of internet and telephones within remote areas. They still have areas where a connection is still not there yet. Those are which are very, very hilly areas where the cost of setting up the infrastructure is very high. So people who live in the valleys, for them to get the connectivity, they have to come up to the hilltop so that they can get the connectivity. So those are some of the challenges which are still there, and government is working on different aspects of that, how to ensure the last mile connectivity. But I think there has been a lot of push from the government on telemedicine as well. And when they came up with the guidelines, they ensured, and they've given 3 years for all the doctors to get trained in telemedicine. So there's also a policy related initiative from the government to ensure that everyone knows what is telemedicine, what are the guidelines, what is required to do, how to manage your data. Even a casual conversation on phone or a chat also is constituted as consultation, and that comes under the ambit of telehealth, telemedicine. So the doctors also need to know how they need to protect themselves and the data of the patients they interact with.
Great, thank you, everyone. Because of time, I'm going to bring us to a close. We just apologise to our French brothers and sisters. I think we lost our translation a few minutes ago, so apologies if that's been more difficult for you the last 10 minutes or so. What an hour or so it's been together. Some amazing stories and discussion. And as we said at the start, this is not a binary issue, is it? This is there's so much in this, and what we've heard is just a privilege and honor for us of being connected. A call like this is self-selecting in some ways, isn't it? Those of us who are here because we are connected, and we have the honor, using Chris's words, the honor and the privilege of being connected. And we've discussed some of the real benefits of helping people to be connected, but also heard the importance of face-to-face connection. And I think what we've seen is some of the nuance of how those go together: face-to-face connections, good community relationships and trust, alongside access to devices and connectivity, internet connection and good training. They seem to all go together, don't they? Off the back of this session, a couple of things will happen. We'll upload this talk, this time to YouTube, and we'll send that out to everybody who registered. Alongside that, there'll just be the suggestion that we'd like to carry this conversation on. At the moment, we've got no agenda and no set way of doing that. If you'd like to be involved in that conversation, then use that email that comes out as your chance to respond and let us know that you'd like to carry on being in that conversation. And maybe we have another call like this, or we set up some kind of working groups across our organizations, across our networks, across our countries on this. It's quite exciting to think of the prospect and the number of us here and what could be done in that. So look out for that email as an invite into that process, and we will mold that together, and any suggestions welcomed into that as well. So let me take this opportunity to thank our presenters. Thank you so much for joining us. Thank you to Tearfund and to CCIH and to those in Arukah who've helped make this happen. And as Christians together, can I close us in prayer? Let me close our time together in prayer. Father God, we thank you for bringing us together in this way. Thank you for the wonders of modern technology in your created world. Thank you that you made us to be in connection with each other, and you are making ways for that to happen in different ways, in more effective ways, in cheaper ways, in ways we can reach more people and improve the health of so many people. Father God, we pray you'd give us wisdom as we go from here in our different roles, in our many different countries, with a reach of thousands between us. Give us wisdom as we move forward. Help us to be productive in this area. In Jesus' name, amen.
Amen.
Amen. Well, thank you so much, everybody. Thanks for being with us.
Thank you, Tom and the team. Thanks so much.